Great. Welcome to the House Healthcare Committee. It is Friday, April 14th, and we are continuing our discussion on S47. This morning, we have with us Morning Fox, who's the Director of Mental Health Programs with the Department of Public Safety. So welcome. And I think we are going to do quick introductions, Morning, because we are all new and I know some people haven't met you yet. So we'll do quick introductions around the table and then I'll turn it over to you, okay? Art?
Yes, hi, morning, Fox. Art Peterson, you remember me from last year, I hope. Rutland District 2.
Hi, Leslie Goldman, from Windham County in the Bells Falls area. Came back.
Seeing you again.
Murray Torres, Lincoln, Bristol, Moncton, Starksboro.
Chopper McFarland from Barrytown, and I represent a part of Williamstown.
Lori Houghton, City of Essex Junction.
Alyssa Black, Essex.
Brian Chino, Burlington.
Alan DeMar, Montgomery and Enosburg.
Melanie Carpenter, Johnson, Wolcott, Hyde Park, and Belvedere.
And Bobby Farley's Rubio, Barnett, Waterford, Reigate.
Pleasure to meet you all.
Great.
For the record, my name is Morning Fox. I'm the Director of Mental Health Programs for the Department of Public Safety. As a little bit of background for the representatives who I haven't met yet, my apologies for not being in person. And such would have liked to have been there to shake hands and say hello face to face. For just a little bit of background, I have testified for this committee over the last several years, but prior to now, it's usually been as my role as Deputy Commissioner for the Department of Mental Health. And so I'm very pleased to be able to be here today. I will keep my comments fairly short. And then I'm here and available to answer any questions that any of you folks may have. In reference to S47, the Department of Public Safety is really not opposed to much of how this language is developing at this point. And we're really pleased with a lot of the collaborative work that we've been doing with the Vermont Care Partners and the designated agencies to work on some of this revision to this law. In regards to Jack McCullough's proposed language from Vermont Legal Aid Disability Law Project, one of the proposals that Jack put forward is that the application shall be based on facts personally observed by the applicant or shall be supported by a statement of facts signed under penalty of perjury by a person who's personally observed the facts from the basis of this to form the basis of the application. Public safety, we're not opposed to that language. We agree that there should be that personal observation to help protect the rights of individuals, and that it may not be possible at all times for either law enforcement personnel or a qualified mental health professional to personally observe those behaviors. And so having the ability to have a signed statement stating those facts is not something we're opposed to. And most law enforcement folks are used to working with individuals to get affidavits in other areas of law enforcement. And so this would just be, another area where law enforcement would be seeking signed affidavits from witnesses. I know that this, could create some delays in this process in general, but that's not something that, from a public safety standpoint, that we're not opposed to this, but I just think the committee should be aware that this could create some delays in that process as that goes forward. The other piece that Jack McCullough put forward in his proposal is that the authority to transport the person shall expire if the person is not taken into custody and transported to a hospital within 72 hours of the time the warrant is executed. And again, Department of Public Safety, we're not opposed to this language. 72 hours can be a fairly quick turnaround in trying to manage this. Sometimes the warrant process takes several hours just in and of itself, as well as coordinating transports and such like that, sometimes can take time. However, the 72 hours does seem consistent with other areas within statute. The Department of Mental Health, once they've received a warrant or an emergency exam application, Department of Mental Health has 72 hours to submit that and file it with a court. And then there's another 72-hour period where a judge has 72 hours to do a probable cause review. And so the 72 hours here does seem somewhat consistent with those other markers. So again, we're not opposed to any of that. One thing that we would like to bring to the attention of the committee in draft 1.1, at the very bottom of page 1 and beginning of page 2, so we're looking at, let's see here, this is under 7505, section B1, it looks like, starting around line 20 on the first page. Law enforcement officer or a mental health professional shall apply to the court for the warrant without delay while the person is in temporary custody. Once application to the court for the warrant has been made, the law enforcement officer or mental health professional clinically indicated may transport. The one piece I wanted to just discuss here is that once an application to the court for the warrant has been made, that's when the way we read this is that the application, the entire warrant has to be submitted to the judge before anyone may transport the person. And so, again, that brings to question, are we talking about the warrant application? Are we talking about the warrant accompanied by a signed affidavit? And it can take hours to write the warrant out, get all the information, as well as working with any witnesses that may have to sign an affidavit. And so my question would be so where is the individual during this time? And, they've been taken into temporary custody, but are we having to kind of sit with them and unable to actually turn the keys on in the cruiser and start the transport until everything has actually been submitted to the judge? And so one suggestion that we will put forward here is that instead of the language being once the application to the court for the warrant has been made, that I don't have the exact language, and I leave this open to some of the lawyers and maybe Katie can help us as well, but language that speaks more to the effect of once the warrant process has begun. In other words, once pen is being put to paper to write the warrant, that decision's been made and warrant is actually being written, and that process has started, that at that point, if the person has been taken into temporary custody, they may be transported at that point. And maybe some other language to be added to that and the mental health professional or law enforcement shall complete the warrant either prior to or upon arrival to the hospital or wherever they're being transported to. But something to that nature. There's the language once the application to the court for the warrant has been made, that just leaves open the concern that we'd be sitting somewhere, either at someone's home, someplace residence, some business, some streets, anywhere, unable to transport someone, take them into temporary custody. But we wouldn't want someone to be sitting in temporary custody in the backseat of a cruiser while people are finishing up all this paperwork and such. I think we'd like to be able to have them transported to a better environment than the backseat of a cruiser while that application is being done, and also guarantee that the application has to be completed, and that it's not that we start it, transport someone, and then no one finishes it, and so that there should be some language to speak to that as well.
Great, thank you. I made some notes. Katie just arrived, so we'll talk with her later. Let me just finish my notes. So can is that the testimony before I start asking questions? Great.
Yes. Yes.
I have one and then I'll open it up to everyone. In the beginning, you said that you're not opposed to Jack McCullough's first instance of changes, but that it could create delays in the process. Can you expand on that and tell us what delays and where in the process?
Well, I think the place that I see the potential for delays is the requirement for having a signed affidavit. By adding that piece in personal observation, if someone's there to personally observe it, there's no delay. They've seen it, they're able to report it, they're able to document it and put that into the application for the warrant. However, if an officer or mental health professional didn't personally observe the behaviors, and there's a need to get a signed affidavit from a witness, that could take some time, both in getting just the witness to write out this information, and sometimes there may be witnesses that may not be comfortable doing that, and so it's going to take some time to have those conversations I think in that circumstance, hopefully to elicit their cooperation in signing that affidavit.
Okay, thank you. That's helpful. Anyone have questions?
I have one. Mr. Fox, a person who observes something who's going to sign an affidavit, does that mean that the officer or the professional that's there must take that person into custody, or can? I assume it's can. I mean,
May.
May take the person. So that person's going to go investigate the whole thing, and he may find that no, the person's fine. We don't need to do anything. Is that fair to say that can happen?
Right, and I think that would be a collaborative conversation, between an officer, mental health professionals, witnesses, to determine, the reliability of the report, things of that sort, the accuracy.
I think that's what I was getting at. Okay. Thank you.
Alyssa?
Good morning, Fox. Morning, Fox. So I guess we've had, this is, to me personally, and I know this is a really basic question, we've gotten a lot of background on the transport, but I don't think I personally am actually really clear about, what types of scenarios, what sort of situations are we talking about? Is there kind of can you give us sort of like a snapshot of a typical situation where, law enforcement and, perhaps a mental health professional would be, what types of situations are we talking about here?
Well, I think the quick answer is a joking no, that I couldn't say it because I don't think there's what you could call typical. I think it's a wide range of possible scenarios, from my 10 years of working at Department of Mental Health and 20 years prior to that working in the field. These situations can range from a person with a mental illness becoming assaultive and maybe hitting a family member, or something of that sort. And so they're responding to that type of an incident. It could be the other extreme of, a elderly person who has a mental illness, and due to their mental illness, their paranoia has told them the water is poisoned, and so they're no longer hydrating, and now their health is at risk due to dehydration, and they're unwilling to receive treatment. And so it can really range in scenarios what we're talking about, but the basic tenets are any situation where you have a person who has a mental illness, and as a result of that mental illness has either engaged in dangerous behavior toward themselves or others. And so, that the warrants could be for, a very wide range of types of situations, but I think those two cover kind of the extremes that you would see.
Since we're talking about sort of emergency transport, is there usually like a high level of acuity in these situations?
Again, that's variable. I would say that generally you're talking about higher acuity situations. You're talking about looking at an individual who has potentially injured someone at that time and is really struggling with their mental illness. And so I would say that the general sense would be that, yeah, there is probably going to be a higher acuity at that moment. I think, Roger Marcoux, the sheriff from Lamoille County, in his testimony yesterday talked about the great success they've had in transporting individuals without restraints. I want to remind, the committee that the transports that Sheriff Marcoux is referring to, and I'm extremely pleased with those numbers, don't get me wrong, but I just want to be clear that the transports that he is referring to are from emergency rooms to an inpatient facility, not from the field to, say, an emergency room or some other location. And so generally there's been a bit more time, and there may or may not have happened, but there's been more time, so the person has possibly been able to de-escalate. The sheriffs are able to spend significant amount of time building a rapport with an individual, trying to elicit a safe transport. Out in the field, where it's a little less contained, that can be a bit more difficult.
Thank you, that's helpful.
Yeah.
How many instances a year does the state police deal with on this? Is there an average, or?
I honestly don't know the number, to be honest with you. I think we're talking fairly small numbers where Vermont State Police troopers are actually the authors of warrants. I do know it happens. I just don't know the exact number offhand. And as far as their involvement with these, that's probably a higher number where they're involved, but not necessarily the author of the warrant.
Okay, thank you. Art?
Yes, on page 2 of the bill, line 7, number 2, transports conducted pursuant to the subsection shall provide individuals with the same protections as provided to individuals in the custody of the commissioner who is transported pursuant to blah, 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 blah. What the heck does that mean? I'm trying to understand I don't, because I think someone said you could, like a mental health professional could transport in their own vehicle. And I'm trying to figure out the bill. I'm trying to understand the transport thing.
Sure. I will give a very brief 1.5 sentence answer to that, and then I will defer that to my partners over at DMH and Vermont Care Partners. That's their language. But I think this really speaks more to the responsibilities and such like that to the commissioner of DMH versus who can actually provide a transportation and under what circumstance. But I'll let them explain.
Well, I will get the others.
Yeah, we'll hear from Dylan next.
Soon. Okay.
Yeah.
Any other questions for Morning Fox?
Can I ask something not on this bill?
No, you're not.
I wanted to commend him.
Good try. Good try. You can commend him.
Yeah, that's where I'm going.
Okay, that's fine.
So I had an opportunity, Leslie Goldman, and I live near the Westminster Barracks, and I had an opportunity to meet with the sheriff, and not the sheriff, but the lieutenant and the embedded social worker at that barracks, and they were amazing and really doing amazing work and very communicative, and I just wanted to appreciate your work.
Thank you very much. Christine is one of our longer tenured embedded crisis specialists, and I have nothing but high adoration and accolades for her. She's a fantastic person, and Lieutenant French has been at Westminster for some time now, and their working relationship is really fantastic, and I think their connections with the community is as well. So thank you.
Yeah, it was pretty apparent, so thanks.
And I will say, I think at some point we'll want to have you come back in, and there are a couple of us on the committee when we, put that forward. It'd be great to have you come back now a couple of years later and let us know how the program's doing. So we'll put that on the agenda for January.
Fair enough. I look forward to it.
Great. Well, thank you very much. Obviously, you're free to stay on. If you can't, that's fine. If we have any additional questions, we can reach out to you.
I'll remain on for now.
Okay, great. Thank you. Dylan? And I think we have new written testimony from you, right? Or not new, but
Yes, and I'll just summarize that. I won't be long today. I just wanted a chance to quickly respond to some of the testimony yesterday and invited Kristen Chandler to join me. So Dylan Harris, Mental Health Services Director of Vermont Care Partners. And if this works, I could just quickly try to respond to the question that you just posed. I think how I would describe it is the statute had language that said how people in the custody of DMH needed to be transported. And what we're trying to do in this bill is expand those same protections to anyone who's being transported even before they may be in the custody of DMH.
Okay. That makes
can you
sense.
say that again? I really apologize. I was distracted.
The section 7511 describes the protections for people who are in the custody of DMH. So after they've gone through this whole process, and what the language that Representative Peterson referred to is saying we want to expand those same protections to anyone who's being transported even before they're in the custody of the department, before they're determined to have passed a second certification.
Okay. Did that help, Art?
That helps a ton, but what types of things are those? What indices? I'm probably going over it.
Well, it's right here on the under 7511 on page 4, the top of page 4. So, yep.
Okay.
Preventing trauma, respecting the privacy of the individual, the least restrictive means necessary for the safety. And that's kind of the.
Okay, those are the indices, which are kind of common sense, common sense like. Okay, so those are used once they're in DMH. We want them to be used if they have an incident before they get to DMH.
Exactly.
Okay.
Yeah.
All right.
So I guess I just want to make 3 points, and I have a couple specific scenarios. I called on my emergency services directors last night, and they sent me some scenarios, Representative Black, which might be helpful to answer your question too. But I do just want to emphasize that I don't think this revised language is perfect, but I do think that even across all of us, we do have consensus that the current statute's outdated and it needs to be updated. That I think we all agree mental health professionals don't have a role in taking people into temporary custody. That's not what mental health professionals do. And that it makes sense for law enforcement generally to be the person providing transportation, and that those protections exist for all. So I think we cross stakeholders have consensus there. In terms of Jack McCullough's testimony on the warrant expiration, we support the idea of a warrant expiration. That makes sense. From our network's perspective, he proposed 72 hours. There have been situations where it's taken like several days, even once the warrant has been approved, for law enforcement to come do the transport. So we're proposing 5 days instead of 72 hours. And then I just want to comment on the personal observation piece. I think Jack McCullough's story was a powerful one, and I think we all share the goal that people aren't subject to a warrant that isn't based on good data or good information. I think the concerns from emergency services director's perspective are the delays that Morning Fox just spoke about, the time it would take to go potentially find witnesses who had called or who had reported something and make sure that they sign an affidavit. We're also concerned just about if a crisis clinician has to personally observe the behavior that may put them in a more unsafe situation than if they can report on the warrant what was reported to them. And I would just note that unlike law enforcement, crisis clinicians aren't in the practice of obtaining signed affidavits. So like that's a procedure law enforcement do, but as crisis clinicians, I think they would have to get training. That feels like outside the scope of what a mental health practitioner typically does. So that's just a consideration. So I'll just quickly provide some examples to try to kind of put those pieces together. Kristen, do you want to add anything before I jump to those scenarios?
I just, for the record, Kristen Chandler from Team 2, I just want to, I've listened to all the testimony over the last couple of days, and I just feel the need to remind everybody about the point of a mental health warrant. It's to get somebody some help, somebody who is in a crisis, some kind of distress. And I hope that the committee will keep in mind the parity between medical health and mental health. And I've been practicing law for over 30 years, and I teach search and seizure law at Norwich as an adjunct. And there's a balancing here about certainly people's rights to not be seized against their will, the rights of an individual, but they're balanced with the need for law enforcement to do an investigation. And under the mental health statutes that we have tasked both law enforcement and QMHPs with doing what for lack of a better term is an investigation, or really more of an assessment of a person's well-being and whether they meet that legal standard. And just getting them to see a physician or a medical provider at the hospital it is the point of this entire part of the statute. And I just hope people can keep that in mind.
Thank you.
I'll just quickly share some scenarios and then happy to answer any questions. One example that came up was a 52-year-old woman in her home. A sibling comes to visit her. The woman is manic. She attacks her sister, leaving bruises. Sister calls 911 because she is afraid for her safety. And the crisis clinician doesn't personally observe the violence toward the sister, but documented that in the warrant application. All the other criteria were met for the person. The person had a mental illness, the behavior was dangerous, and they linked that behavior to the mental illness, and the person was not voluntary. Anyway, the warrant was granted. A second scenario, a woman was walking in and out of the street and traffic. Observers called 911. Officers intervened and brought her to safety on the side of the road. The crisis clinicians were called. They didn't personally observe the walking in and out of the street, but used the officer's account of the situation to apply for the warrant. And I think this and the next scenario both show you some of that collaborative work that happens between law enforcement, where one person's kind of making sure the individual and the people around them are safe, and one person's applying for the warrant in this teamed approach, team two, that Kristen trains on. And then just a final example, a 47-year-old man in a local coffee shop, verbally threatening other patrons, utilizing inappropriate sexualized language and getting in people's spaces. The patrons are afraid for their safety. 911 is called, police arrive, police detain the person so he discontinues the behavior towards others. Crisis clinicians are called, crisis clinicians apply for the warrant and didn't personally observe him, but also again wrote the information given by the police. So I just wanted to give you some examples from the field and why that we feel that having the language that you're required to have personal observation in the statute, it's there, is kind of finding that balance between some of the practical applications and people's rights.
Art?
Yes, and I'm glad you gave us those examples, because right now, without this bill, can those be taken care of or not?
Yes.
Okay.
Yeah.
So what does this bill do to help that? I'm still struggling to see what the bill does to help anything.
Well, one thing the bill does, as in the language we proposed, is clarify the roles. So those scenarios worked out in this collaborative approach, but we've struggled with sometimes law enforcement saying, you take the person into temporary custody. I mean, that's why we were trying to make it much clearer.
Okay.
Yesterday, Jack McCullough and Wilda talked about personal observation as well. We're saying that there should be a signed affidavit, but either the person should personally observe.
And right now there isn't?
Right now, there's not a signed affidavit.
Okay.
And so, I think we all understand both sides of the argument, but we're trying to concerned about the timeliness and just kind of how it plays out in the field, feeling like a documented description.
And I'm trying to understand that. So the signed affidavit is one thing. what about the transport changes? Anything or? I know it's what we just covered.
Yeah.
But that seems so commonsensical. I don't know, maybe not, but I'm just trying to, I mean, I support all I see here. I'm just wondering what this really does in the field when there's a situation.
Yeah.
Kristen, can you give an example?
Well, I just think, the examples that Dylan has provided are all from Washington County. And I will just point out, the training that I do is statewide. So I've gone to every county in the state, and Washington County has enjoyed this collaborative approach for over 25 years, where it works really well, where there's good communication between law enforcement and the mental health providers. Other parts of the state, that doesn't happen as like it does in Washington County. And so you do have, we've had several instances over the last couple of years where people are literally arguing, pointing fingers at each other, a police officer to a QMHP, well, the law says you can transport them, so you transport them. I'm not going to do it. And that is really what we're trying to hear.
Okay. Where is that in the bill? I'm sorry.
That's okay.
Yeah. Where is that in the bill? Where does it talk about that? Just so I can see it.
Sorry, I'm trying to pull the bill up.
Dylan, do you have that in front of you?
Do you have it, Katie?
Section 1.
Yep.
Okay.
Katie, can you introduce yourself?
Yes, Katie McDonough, Office of Legislative Counsel, Section 1, 18 VSA 7505. And then in subsection B, subdivision 1, we're striking or mental health professional from the persons who can take a person into temporary custody. And then we're saying, and a law enforcement officer or a mental health professional can apply to the warrant for the court. And then there's language that the transportation happens by the law enforcement officer or the mental health professional, but only if clinically appropriate to do so with regard to the mental health professional may transport the person.
Oh, okay. So it gives both entities the right to.
So right now, correct me if I'm wrong, Katie, right now, the law says that both entities may transport the person into temporary custody. We're saying the law enforcement officer may take the person into temporary custody, and the law enforcement officer or the mental health professional can apply for the warrant, right?
Okay.
Once the application to the court for the warrant has been made, then the law enforcement or mental health professional, only if it's clinically appropriate. That's the only can transport. So that's the
right. All right.
And right now it's saying both. And so there's this ambiguity sometimes in situations. Did I get that right? You got it. Okay.
Okay.
Yeah.
Yeah. All right.
Yeah. So before you came, Morning Fox was here, he's still here, and had a concern about where the individual is while the warrant is being sought. And I was just wondering, it says once the application to the court for the warrant has been made, they may transport the the person. Does that answer his question?
So Katie wasn't here for that.
Right.
So
that's why I'm thinking that maybe
that's
he could.
what he wants to do,
Yeah.
Let's continue with this.
Okay.
And we'll come back and talk to Katie about the suggestions from Morning Fox. So I want to go back to the 72 hours versus 5 days. So in Morning Fox's testimony, it sounded very logical, right? 72 hours for the transport, and you got 72 hours so why 5 days? Can you give me some reasons?
Yeah, I wish I could give a more specific example. It has to do with, I just know our providers have said more than multiple scenarios because law enforcement hasn't taken action on the warrant that's already been approved. It can take days and days. Like maybe they call law enforcement on a Monday or Tuesday and have to keep calling and they're still not going out and they go out Friday. And the idea was then they wouldn't have to apply again for the warrant on Thursday. That would be 5 days. Kristen, I don't know if you have any comments on that too. I'm not sure the difference between 72 and 5 days is going to come up that often, but.
Well, I know we're definitely in agreement about having an expiration period, because what we don't want is for a warrant to be active and the person not to be found. And I totally agree with Jack's testimony yesterday about, yeah, I mean, somebody may present an entirely different way, hours after the warrant has initially been applied for. I think the 5 days came from, in criminal law, for search warrants and arrest warrants, the template is they expire in 10 days. And so this was like half of that time. And also given the real scenarios from people who've been, boots on the ground, with that scenario that Dylan just talked about, where while they're making a plan between law enforcement and mental health providers, and this really, again, has been impacted with the use of force law. And I think we're getting into the sort of judiciary's realm here, but that's really impacted the service of warrants since late of 2021. So there's been a bit of a delay, more of a delay, while people are making a plan.
And the delay is on where in the process? Okay. And maybe I just don't understand like how the process works to get a warrant. That might be part of my.
Yeah, I can speak to that. The way we want it to work, and the way it is supposed to work is, the QMHP generally starts that process when they've made that assessment of the person, they decide they meet legal criteria, and they tell the police, okay, yeah, I'm going to write papers. And the police then take the person into custody. And then in that custody, they're not sitting at the side of the road. They're transporting them generally to an emergency department, sometimes to a barracks. And the QMHP is writing the warrant. And then once the warrant is written, the QMHP is going to meet the officer at the hospital. Then the QMHP is calling the judge on call and trying to get a hold of a judge. And sometimes that can also be a delay, but in best case scenario, they can reach the judge who's actually the first one on the list for that particular day or night. And then the judge reviews it for a probable cause and either grants it or doesn't. And most of the time it's granted. There certainly have been times where a judge has not agreed and has not granted the warrant, but then the person is where they're supposed to be in order to see a physician or see a medical provider. They're already at the emergency department and there they are. And there is no more delay in having them examined. And just keep in mind, this doesn't mean necessarily they're going to be involuntarily treated, committed, I should say. They're definitely involuntarily going to the hospital, but they're going to just be evaluated by a doctor or examined by a doctor. And then there may be other consequences that flow from that. But initially, this warrant is just a way to get them transported to a physician or a medical provider.
Thank you, Melanie.
So it's not that someone could be in custody temporary custody for like 5 days before their warrant is finalized?
No, the statute also says if they're in temporary custody, they need to be seen immediately by a doctor.
Okay.
So that protects the person there. Okay. But it's not, it's still kind of vague about where is this temporary custody. And Fox touched on this. We don't want people sitting by the side of the road or sitting in a barracks for a lengthy period of time while this process is playing out, or collecting affidavits, or whatever we need to do, trying to find a judge, etc. The officers are generally they're either waiting until the warrant is signed by a judge before they even pick up the person or respond, or in some cases they're going ahead and putting that person into temporary custody and transporting them to an emergency department while they wait for the warrant.
Then that evaluation can happen while the warrant is, like, say it's taking a while to find the judge to complete the warrant. That doesn't pause the immediate need to see and be evaluated. Am I right?
It does pause that because the warrant says you're going to be seen by a doctor. So they're waiting in the emergency department as opposed to waiting in, by the side of the road.
I'd like to just actually offer an example that might make it clear, the 72 and the 5-day thing. Just I'm thinking of a scenario, I'm thinking of Fox's example of the older, I think, woman with whose mental health or mental illness was leading to dehydration. So that client may be a CRT client, a person with serious mental illness being served by the designated agency, and the treatment team may feel that this is necessary, may apply for a warrant. So law enforcement isn't involved at all. And what our providers have told us is we get the warrant, the judge approves the warrant, and yet then we call law enforcement and they don't come for a few days, or maybe sometimes it can take a week to get them to come. And so that's why the 72-hour expiration in that context, we thought a 5-day would work better based on some experiences of law enforcement not coming when the warrant's been applied for separate from law enforcement.
I guess my concern was that someone gets taken into temporary custody, the warrant is taking a long time, the person is sitting in barracks for 5 days with no, that's not what this is. That would not happen in that situation.
No, because somebody's gonna find a judge, within a much shorter time frame than 5 days. If it took 5 days to find the judge, that's a real problem. But that has never been an issue here. Occasionally has been an issue, and by here I mean in Vermont. There's been an issue with reaching the judge who has been on a list that either law enforcement or the QMHP has, that's the person on call that they're supposed to contact. But then they just go to the next judge. And we have great communication with Judge Zone and the judiciary about working out any kinks that there have been. And I'll just tell you, for example, getting these warrants by telephone has been incredibly helpful and helped to speed up this process of getting somebody some help. There was a judge a couple of years ago who insisted for any warrant, he wanted to meet people in person at the courthouse. And that really delayed things. And once we just pointed that out to the administrative judge, hey, mental health warrants, the point of them is to, get people help. Then there was a directive given, and it was like, okay, for mental health warrants, let's not make people show up in person to get them signed. We can do this over the phone. Sometimes it's also done through email, but it has to be encrypted because there's health information on there. So that if a judge insists on an emailed warrant, that can sometimes delay it depending on what county we're in and what's available to the QMHP who is trying to send that warrant. But generally they're done by phone. And so that there isn't much delay at all in that piece of it to get a hold of the judge who's either going to approve it or not.
So I know there's some more questions. Kristen and Dylan, if you can still stay, I want to move to Karen Barber, who's been waiting to testify. There might be some more questions for you, so I'd appreciate if you stay. Karen, are you there? Hi, sorry, Karen.
No worries.
How are you today?
I'm good. How are you?
Good. Thanks for being here. So if you can just introduce yourself for the record.
Yeah, absolutely. So good morning. My name is Karen Barber, and I am General Counsel for the Department of Mental Health. And I don't know that I know a lot of you, but I've been in this position since 2014. So I appreciate the ability to be here today and also the flexibility. I know I was scheduled originally for yesterday and I was in House Judiciary, so I appreciate you letting me go today. I did try to watch yesterday's testimony so I could be prepared to answer questions, but please feel free to ask me any if I don't cover what you're curious about. But so as background, and I'm sure VCP has testified about this before, but the idea of this bill really came out of VCP letting DMH know that they had some concerns with how the process was actually working in the field. We started to have larger conversations over the summer, and that kind of culminated in this bill. DMH did have some concerns about the language as introduced and how it passed out of the Senate, but we have worked with VCP since the bill made crossover, and our concerns have been addressed with the language that I worked on with VCP. However, I do still see an issue with draft 1.1. I think it's an oversight, and I'll explain why in a minute, but most of that is the language that Dylan and I had agreed to. But before I get to the bill itself, I just wanted to thank BCP for working so cooperatively with us to address our concerns. I think when Dylan and I really sat down and talked about them, we weren't necessarily on different pages. It was just more making sure the language accurately represented intent. I'll also say that DMH, I like the tweak that Fox was talking about in terms of the language. I think that was the intent that Dylan and I talked about, and maybe we didn't do a great job at coming up at language. So we will look forward to working with Katie on that. But just to go through, so what were our original concerns? And you've talked about this a little bit, but one of our concerns is the language of 7511. And that is the section really that applies now if someone's in the custody of commissioner and allows us to kind of transport them to and from inpatient units. And it sets out some standards by which we have to make sure they're transported. We were concerned with trying to add additional language to 7511 for folks that weren't in our custody, because not only are they not in our custody, but there was no funding attached to pay for this extra duty. But in speaking with Dylan, it was clear that that wasn't the intent behind it. It was simply to assure the same protections for those being transported on warrants versus those being transported because they're in the custody of the commissioner and we're looking to put them in an inpatient hospital bed. And I think we've really achieved the goal of BCP by adding language to 7505B2 and 7505D2. But the original language that was problematic to DMH that we resolved through these additions still remains, and that's the 7511A emergency department language. So we would ask that that be removed because the intent of adding the two sections was to make it so that we didn't need to make changes to 7511. Does that make sense?
Does that make sense for everyone?
No, I'm not sure which hospital language in 7511 are you referring to?
So I think you're referring to A, right, Karen?
Yes.
So where it says emergency department is underlined, so it's page 3, row 18. Karen, you may not know this answer, but do you know why the Senate, their intent with adding that language?
So that was, and Dylan, correct me if I'm wrong, because I know you're there. I think that was language that BCP originally put in. We didn't testify in the Senate, so they didn't necessarily hear our concern. And so I think, again, the intent was to assure the same protections for the people under the warrant. What the original draft was doing, right, was adding language to 7505 referencing 7511, but the thing is 7511 wasn't about warrants, right? It's about once people are in our custody and giving us the ability to transport them. So we're just trying to tease those two apart.
Okay. And do you ever transport them to emergency departments, or that's already, like, that step has already been done if they were in the emergency department and now they're, okay.
Can I get clarity? I'm not sure, Leslie Goldman, and we haven't met, but it's a pleasure. I'm not sure I understand the problem with the language about transporting to an emergency department in 7511. If you can help me again, sorry.
Sure. So let me tell you right now what 7511 does, right? So when someone is in our custody, they're waiting in an emergency department, they've already gone through the whole process. So an EER warrant is just the beginning, right? Then they need to be seen by a physician and a psychiatrist. And when the psychiatrist determines that they do meet that level of care, then DMH has to file an application for involuntary treatment. Once the second certification is done, that second piece by the psychiatrist, and the psychiatrist has said they need an inpatient level of care, that's the point at which we start looking for a bed. And so then 7511 is allowing us the ability, once someone has determined to actually need that level of care, to transport. It could be that they're in an emergency department in, say, Rutland, and then they go upstairs, so they don't need to be transported. But it could be that they're in an emergency department in UVM and they're going to go to the Brattleboro retreat. So we need to arrange for transport. 7511 11 allows us to do this. By trying to tie it to the warrant statute, all of a sudden, and so what we do, right, we have contracts and we contract with both sheriffs and YTA to do these transports, and we set guidelines around them being done in the least restrictive setting, and we pay for them, right? It costs money to pay for transport. Right now, when you're talking about picking someone up in the community on a warrant and transporting them, those aren't folks in our custody yet, right? Like there's a temporary hold to bring them to then determine whether or not they actually meet the criteria to be in DMH custody. So we don't do that right now because they're not in our custody. And so we don't have a mechanism to try to do that, nor do we have money to all of a sudden create new contracts to try to figure out how to do that. And because these aren't people in our custody, it doesn't really make sense for us to be trying to arrange for their transport. In fact, it'd probably make things more complicated and it would probably take longer, right? So we have a process when we're arranging transport that takes a little bit, but we already know where they are and where they're going. This is kind of trying to work with people in the field to figure out a transport. So they're very different things. Does that make sense?
Yeah, could it be that someone might be in your custody and ends up in this position because of mental illness exacerbation? So that might apply here if they were in your custody?
I guess someone could be on an order of non-hospitalization, but in that case, we wouldn't get a warrant and try to EE them, we'd revoke their ONH. So there's a different process for that. This is really the beginning of the process to determine whether or not they would be in our custody. If they're already in our custody, there are different mechanisms if they need a higher level of care.
Okay, that's helpful. Thank you.
Thanks, Karen. Was that your testimony? So we can start asking other questions, or was there more?
I had one other thing I just wanted to touch on, which was the language that the changes to the language and then what Fox kind of touched on. But our second original concern was along the lines of due process. And I think some of the things that Jack and Wilda touched on is we were concerned that the language as originally written allowed someone to be transported without an assurance that the warrant was actually going to be filed. It said without delay, but we weren't really sure what that meant. And we wanted to assure that there was due process. So that's why we worked with VCP, I think, to come with a different solution than maybe Jack is proposing. But that was, and our intent was, I think, better, again, articulated by Fox, but really was to assure that the process had started before the transport could happen. Not that the process had to be finished, but that we had assurances that they were in fact filing the warrant so that there was some due process started for the person to be transported. So that's the second piece and why we really supported those changes when we worked on with VCP.
Okay, great.
And that was my testimony.
Okay, wonderful. So we have a couple of questions, Daisy and then Alyssa, and then we'll have some.
I have one too.
Hey, Karen, it's wonderful to see you and not be writing notes of your testimony, especially to have you here with Fox. I wonder if two things. One, can you speak to any, and just ballpark any of the numbers of individuals who are either on order of hospitalization, non-hospitalization, or EEs each year, just to give us an idea, the number of individuals who actually go through this process. And then second, I know you were instrumental, before the pandemic and then also going through the pandemic in helping this process continue during a time that the judicial process was really upended. And I'm curious in, drafting this policy, what lessons from that period were you able to bring forward into this, if any?
Those are great questions. I'm not sure I'm the best person to answer them. So in terms of the data question, we can get back to you on that. I don't know off the top of my head. I think on average, we generally have about 300 folks on orders of non-hospitalization and less so on orders of hospitalization. I don't have those exact numbers. The other thing I'd note is there's often a lot of people who are kind of on EE status and haven't formally gone through that order of hospitalization process, but are still in the hospital, just because sometimes that process can take a little bit. But we can get those numbers for you, but just so when you see them, you're not kind of thrown off. In terms of the COVID and the lessons learned from that, so Sam Sweet, who's our director of mental health services for the Department of Mental Health, was also on this VCP kind of study committee where we were talking about these issues. She, because she oversees care management, was originally the care management director, and now in this role, I think had a lot more firsthand experience and would probably be better to answer your question. I was really tasked with what are the legal nuances that we need to make sure we get. So, but we can certainly have Sam try to put something together for you.
It's okay. I wouldn't want to put additional work on her. I was just curious, but it's okay. Thank you.
Thank you. So I have a couple of questions, and then Leslie, I'll go to you. I'm struggling with two things. I'm struggling with the timing, the difference between the times that people are proposing, and I'm struggling with the affidavit. How do you say that word? Affidavit. The paper that has to be signed. So let's start with that one first. So I'm really struggling with why that wouldn't be required even now to take someone into temporary custody. And so my question is, if we're changing this to only the law enforcement officer may take the person into temporary custody, won't that mean that in every situation now a law enforcement officer will be present, therefore they have the capability and the knowledge of how to get that form signed? And I don't know if that's a question for you or maybe Kristen.
Yeah, I think that may be a question for VCP, as you know, as this is their language. I think the Department of Mental Health's overall goal is to make sure people get treatment when they need it. And I think, as Kristen said, the goal of this statute really is to make sure people can get treatment. We rely on our designated agency partners to do this important work in the field. And so our goal really is to make sure there's a balance between meeting their needs and also assuring due process. So it may be better to hear from them as to why we hear both sides, right? We've heard what Jack said. We hear what VCP says. We understand both their concerns. Our overall goal, again, is to just make sure people are getting treatment. I don't know that we have specific thoughts as to which one makes more sense, as long as both those are being met.
Okay, so that's helpful to know that DMH doesn't really take a position on either of those. Okay, and then, or on the form. And then on the 72 hours and talking about, people getting treatment. So someone's on the side of the road. They're taken into temporary custody. The warrant's going through the stages. That person is taken to a police barracks or another safe location. They're not taken to the hospital. When does that person see a doctor?
That is a great question. That maybe Fox and his, I don't know if Fox is still on, maybe Fox and his experience might be better able to answer. Again, I can talk to kind of the legal nuances, but how it practically works in the field, I'm not sure I'm your best person to answer that.
Can you tell me about the legal nuances? I'm actually very interested in that. So like when, they're still not in DMH custody, right? Even though they're in temporary custody, they're still not DMH's custody. So who has the authority over how that treatment process starts? I mean, it's not treatment necessarily, but seeing a doctor.
Well, right. The goal of the warrant is to get someone to see a doctor, right? And so really it should be to get them to a doctor. That starts the process. So as quickly as possible, they shouldn't be, I think the idea behind this, right, is that we don't want them just sitting places while we're waiting for the actual warrant to go through. We want them to be able to be transported quicker so that they're seeing a doctor quicker, because that's what really starts the process, right? The physician has to do the first certification and then a psychiatrist does the second certification. So the goal the goal is always to get them to see a doctor as soon as possible. My understanding from VCP is they felt that the language as written was really kind of hindering their ability to do that and assure that happened quickly. And so this language was really their attempt to try to make it more efficient.
Okay. So this is a question for whoever can answer it. So does the 72 hours or the 5 days hinder or delay someone getting the treatment? And I'm going to go back to Morning Fox's example where it was an elderly woman who was dehydrated. I mean, shouldn't that woman just get treatment? So I'm wondering what the nuances are there and how the timing of the 72 and the 5 days may affect that. So I don't know who that's for.
Well, I see Kristen popped up. So do you want to take first step?
Here I am, Karen, the two lawyers answering the clinical question. How great is that? I will say, and a lot of this is from
Morning Fox.
My years of being right next to Fox in the numerous trainings that we've done together. But that 72 hours or the 5 days would not affect how quickly shouldn't affect how quickly somebody saw a doctor. Right, that 72 hours that Jack's proposing, or the 5 days, is when we want the warrant to expire, right? So this is the answer, I think, to your question about, yes, we want that woman to get that help. And the statute says, you know, that the officers can transport people to a hospital, which is why we're telling them, when you take them into temporary custody, get them to the emergency room, because that's where they're going to be seen anyway. And there shouldn't be, and the statute provides for that physician to see them as soon as possible. It's already in the language, and we're not proposing to change that. So it shouldn't impact how quickly, as long as the officer is, you know, as long as the judge is able to be located, you know, quickly. It shouldn't impact how soon that person might see a doctor and then maybe receive treatment.
Okay. And is there a time, and Maureen, I'll let you talk in a minute. Is there a time on this now? The warrant, this process, there's no time. There's none right now.
I'll just tell you quickly, this came up as an issue a few years ago where a person bolted from their therapist's office. You know, they'd been in had an appointment. The therapist was concerned to the point where they got the people together and wrote they got a warrant. A judge signed it, and now they're out looking for this person, right? So it wasn't until 30 days later, some long period of time later, the person was pulled over for a traffic infraction, and the warrant showed up in the system, and the officer was like, "This guy seems fine to me, but there's this active mental health warrant in the system. So what do I do?" And I know that the trooper called DMH Legal, got some advice. They're like, "Well, it's an active warrant, you know, you're going to have to bring him in." And they brought him into a hospital. The guy got seen. Like 20 days had gone by. And at that point, he was fine. But he had this transport, unnecessary, to a hospital just to be seen by a doctor who then said, he's okay, I'm not going to sign this. And then he had to be taken back. But this is that was the one case that really sort of raised a red flag for all of us in the system about, oh yeah, we need to have an expiration date for these.
Okay. Maureen, did you want to add anything? I know we have a question waiting, but I want to hear from you.
Yeah, just very quickly. I agree with Kristen that, you know, from a clinical perspective, it's not about delaying or speeding up access to a doctor, but it's more about that there should be a termination to the time limit on this, just like in that example that Kristen just gave, that, you know, people's mental status can change fairly quickly and can no longer meet the actual criteria for a warrant. That's why the designated agencies, when someone is under either warrant or EE status, awaiting for a bed in an emergency room, they're being reassessed every 12 hours or at least twice a day to just determine just that. Are they still meeting that criteria and such? And so, you know, I think the 72 hours is more about, or 5 days is more about the need to ensure that there's a termination to this, that it's not just kind of hanging out there ongoing. Again, so that you don't have an unnecessary transport, an unnecessary seizure of a person's body and transportation. So.
Okay, that was very helpful. Thank you. Art?
Yeah, and still trying to totally understand this B1, line 18 on page 1, which we talked about a minute ago, and it just clicked in with me that we're taking out the mental health professional from taking the person into temporary custody. And I want to, I guess, get a reason for that. Is it a safety concern or a competence on the part of the mental health professional to properly take the person into custody? Is that why we're limiting it only to law enforcement, or does law enforcement do 99.9% of them anyway? I wondered why we're doing that.
That proposal's been made, and that was, as I recall, and Dylan, correct me if I'm wrong, that was agreed to by everybody in the stakeholder group that met for over 6 months, because QMHPs are not trained in how to take people into custody, right? Law enforcement officers are. And that's why we wanted to try to stop this finger pointing thing that happens occasionally, where because the law says, you actually have the authority to do this, that we don't want officers pointing their fingers at QMHPs to do that. QMHPs are not equipped. They don't have the training to do that.
Thank you very much. Yep.
Leslie.
Thank you all. I'm a little, it's a little murky for me about the judge's involvement. I've heard email, I've heard written, I've heard phone call, I've heard in person. I'm not sure I understand that process, and I would appreciate some clarity.
Karen, what do you want to do here?
Yeah, who wants this one?
You can do it, Kristen.
Okay, sure. So the judiciary puts out a list of which judges are on call. There's usually 2 in the state, 1 for the northern part, 1 for the southern part. And that gets distributed. Dispatch is aware of who's on call. Generally, police departments access that, and the QMHPs, all the emergency services teams in the state can access that list. And so that's who they know to call. Generally, it's a phone call from wherever they are with the person. Sometimes the emergency department, sometimes it might be somewhere else, like what there've been many situations where things are happening in the field, and judges are being called by a QMHP from the field. And that's usually the process. Now, judges are people too, and everybody has sort of a different, can have a different take on it. There occasionally has been a judge who has been really excited about the ability to email encrypted, health information. And so on occasion, there's been a judge who has asked that the warrant be emailed to them, or it may be that that's just their practice. They much rather read something than be read it over the phone. But generally, the judge is swearing in the QMHP over the phone. The QMHP is reading them their affidavit, because they're filling out an affidavit signed under penalty of perjury that should have all of the clinical indications, as well as the how this person is a danger to themselves or to others. And then the judge is telling the QMHP over the phone how to sign it. Either, Karen Barber for Judge Zone A, or sign Judge Zone A by Karen Barber QMHP. However that judge wants that to be done. Sometimes they will say then, there was one situation where, because of a snowstorm, it was the middle of the day, the judge said just orally, you're good to go. Go ahead and take the person, and then don't drive over here in the snow. Bring it to me tomorrow when the storm clears, and I'll sign it. That makes police very nervous. And so just the way that it works in the field is some police officers will not want to transport somebody without an actual signed warrant. So that's why judges might tell somebody over the phone how to sign it on their behalf. But it's not, I would say it's not consistent among every judge in Vermont.
So does that seem like a weakness in the system, that different, I mean, I'm just wondering about this verbal, okay, is that considered a legal record? I don't really understand how that works, but I don't know if you want to spend a lot of
That's
time.
not what we have in front of us.
I'm just thinking about transport and what's legit in the, in that realm.
We can,
Yeah, I feel like a little bit, we're getting in the weeds a little bit.
we are, Kristen. I think we're fine. Leslie can talk to someone offline on that.
I will say the benefit of working in a small state is that we have these great lines of communication. When if there's ever any gap like that, we can immediately get input from Judge Zone. Very helpful.
Great. Any other questions for any of the witnesses? Great. Thank you all very much. We're going to have just a little bit of a conversation here, and then we will be taking this up again on Monday to have a committee discussion. I don't know, Dylan, if you can be available on.
I'm not saying Monday.
I mean Tuesday. I'm sorry. Tuesday. So everyone, thank you very much. Hold on. We're still in session. So thank you everyone that's on Zoom. Appreciate your time. Feel free to stay or not, whatever you want to do. Thank you. So where I think we are with this, we have a suggested language that everyone seems to agree to that Morning Fox talked about. And so what I'd like to do is work with Katie offline and have her mark it up with that. So don't change any of the language that's in now. She'll layer this on top like they do. And then also DMH's request to have emergency department removed. It'll still be in there, but it'll be marked up that it's going to be removed. I think what we have to have for a committee discussion is the 2 lines of thought between 72 hours and 5 days, an affidavit or no affidavit. So that we'll tackle that on Tuesday. This bill will be reviewed by a judiciary, so they will deal with the constitutionality of it. We deal with this other part of it. So, and then obviously the overall policy we'll talk about on Tuesday as well. So
could you clarify for me, sorry, when you're saying affidavit, you're talking about authorization to transport while the affidavit's being completed? Is that what?
No, I'm saying Jack McCullough provided testimony yesterday that he would like, and I'm probably not going to say this right, so correct me anyone, right now, and in the language that we have in front of us, someone could be taken into temporary custody based on not the law enforcement officer and not the mental health professional.
Oh, the unobserved thing.
Right. Got it. Versus Jack McCullough saying you should get an affidavit from the person who saw.
Okay, the affidavit language is not in here.
No.
Okay.
That's being requested by Jack McCullough.
Gotcha.
It's in his testimony from yesterday. So it's on the. Yes. Yep.
All right.
So those will be policy decisions we will have to make. So it does say possible vote on Tuesday. That will not happen. We're going to let judiciary take some testimony late next week. So we'll keep working on what we need to work on while they're working on that. And then.
Will that take care of some of what Wells was bringing up yesterday?
Yes.
They'll address that.
They'll address that part. Yes.
You know, this is just a comment, and it's dawning on me that we've heard examples of case studies of situations where this would apply. We've heard from psychiatric survivors like Wilda, but I can't think of if we've heard from anybody who's been through this and given feedback on its effectiveness.
Was there any lived experience in the stakeholder group that met?
We had psychiatric survivors was invited to Chapman meeting, so one meeting was on the notes. Chapman, yeah. And NAMI also actually was a member, and so from a family member perspective, they were in and out just because of some leadership changes. But so Logan's testimony, Kareem was present. He didn't provide any suggested changes.
Did he support it?
I didn't get any, his attendance was limited, and he never, when I kind of sent it out to everyone and said, tell me if you support this, didn't get a response. No.
If you can think of someone we need to have in, that's great. will get with me and we'll chat with Claire, but, it also, you know, one of the reasons why we do the process we do, which is put it on the agenda, have testimony, keep it on the agenda. We don't vote things out of here, you know, the same day, is so that hopefully people are all paying attention and can say, oh, I want to testify, or I want to give written testimony. So,
Yeah.
But yes, to your point. But I mean, Wilda provided a personal experience. So she's speaking from lived experience as well. Art?
Well, in regard to that, and I'm glad you said that, Lori, the affidavit thing, you know, I can see cases where people, I wonder if we institute it and somebody doesn't want to sign, where that leads everybody.
Right.
It's just something that.
Well, and it's interesting you say that, and this is totally not related to mental health, but we live on a very busy street, and we heard a fight one evening, and we called the police. By the time police got there, the fight was gone, and my husband did not want to sign the affidavit.
Yeah. So in this case, you know.
Right, but so what's the constitutionality of, you know, where's the due process, right? So I think we can make a policy decision on that, but I think that will also come up in the judiciary.
On that same regards, I said the same thing. You know, these professionals in these state police and, you know, outlaw enforcers, they're trained in that. And they should be able to make a decision. If this person is
right, but what if they didn't see it?
Well, that's true. But how many times, like you say, you know, you didn't want to sign the affidavit because you didn't know what type of fight it was. You didn't know how bad the fight was. People are not going to do that.
Right.
If you think about it, how many of you would do that? Put yourself out there for an affidavit accusing something of being, you know, damaging to somebody.
And I can see both ways, right? So I can see that, and then the person doesn't get help. I can see the other side too, that, you know, you really want to make sure that the person really is experiencing a crisis and needs help, and not just make some assumptions because someone else saw. So it's a tricky one. I mean, it
is, and that's
you got to give the.
It's not rightly done. You know?
To the enforcements of these to determine whether they're harmful to themselves or somebody else. Not always that affidavit. You've got these people are got to make some decisions.
Right.
To the best of the public and themselves.
Yes, and don't rely just on a potential affidavit. I can see that too.
And I think also looking at, you know, I'm looking at the bigger picture. There was just, I don't know if it's just that it coincidentally hit my inbox last week or if it's an old news, but Mental Health America posted a statement or a blog that they condemn involuntary treatment. And that's a big statement. And they noted like the reason they did it or that they condemn it is because it represents I don't know if failure is the word they used, but weakness, failure in the ability to get people to the care that they need and deserve. And like, that really struck me, you know, like we have and so that's why I was asking about the numbers of people that need this. I'm curious how that's, you know, are we improving that? It's the RDA thing, like, are we getting better? Are we getting worse? And so I think at least we can start looking at that number. And if we have to do this, at least make sure that we're making strides to fix it on the other end.
Yeah. Leslie?
I understand this is going to judiciary. I want to understand what's our responsibility and what's their responsibility as I think about this girl. So which sections are ours?
The whole thing is ours.
Whole thing is ours.
So
what are they?
So it's current statute.
Okay.
Right? The question is it even current statute constitutional?
Okay.
Okay. That's not our job, but our job is to look at the current statute and say, okay, these are the suggestions that are coming before us. What's the policy? We're going to make the assumption I'm going to make the assumption that the statute is constitutional.
Okay, so they're deciding constitutionality and we're doing the rest.
Yeah.
Got it.
Yes.
And if they come back and say it's not constitutional, then we're done with this.
Potentially.
Yeah.
A policy just, yeah, most likely. I mean, if they come back and say it's completely unconstitutional, but
But they'll fix it, right? I mean, they'd have to,
but I don't know what they'll do. Wait and see.
Change the Constitution.
So, all right, great. Thank you all. We are back here right at 1. I hope everyone goes outside to eat lunch.